My presentation is about obsessive-compulsive disorder. OCD is characterized by the experience of obsessions or compulsions, or sometimes both symptoms. The disorder has a strong cognitive element, driven by fears and anxiety. A compulsion is a repetitive or ritualized behavior pattern the individual feels driven to perform to prevent a negative outcome. The behavior can be either a physical or mental act. The negative event the sufferer fears has no relationship to the compulsions they perform as its solution. Sufferers recognize these behaviors as excessive, with 78% describing the compulsions as ridiculous, but still feeling unable to break the rigid pattern of their performance. Compulsions are commonly related to avoiding contamination, performing magically protective acts, or repeated checking. Although acting out the compulsion is due to a belief it can prevent a catastrophic event, often the behavior does not alleviate anxiety. In fact, it can intensify. The sufferer gains no pleasure in completing the compulsions, and their frequency can be debilitating. Obsessions are defined as intrusive and recurrent thoughts that an individual finds disturbing and uncontrollable. Often these thoughts inform the compulsion. For example, washing excessively because of a fear of contamination. Other common obsessions include thoughts of harming oneself or loved ones, or pathological doubt, often resulting in compulsive checking. These obsessions can be completely unanticipated and cause distress to the person experiencing them. Research suggests that OCD affects women and men almost equally. The onset is gradual, usually manifesting in early childhood or late adolescence, and is usually triggered by a traumatic event or brain injury. Lifetime prevalence is around 2.5%, with early onset being more frequent in males. 1/3 of those diagnosed have problems with hoarding, and the main compulsions of washing and checking rarely co-occur in the same individual. The cognitive approach highlights the importance of dysfunctional beliefs and their appraisals by sufferers. One construct under the cognitive theory is inflated responsibility, where someone believes their intrusive thoughts have the power to bring about a negative event or prevent it. Research has shown this can lead to vulnerability in developing OCD. These thoughts are meaningful to the individual, and it is seen as essential to the sufferer to prevent the imagined event happening. This can result in feeling compelled to neutralize the thought either mentally or by compulsive behaviors. They may perceive no definitive end of threat, allowing them to let the thought go, making it difficult for them to feel they have done enough of the neutralizing behavior to stave off the threat. Sometimes the sufferer tries to overcome their fear by thought suppression. However, this appears counterproductive, as it has been shown to result in a paradoxical rebound effect, with individuals reporting greater frequency of an unwanted thought after trying to suppress. A study by Bouchard, Room, and Laudeser examined the effect of inflated responsibility and perfectionism on compulsive checking. The researchers manipulated the degree of responsibility participants felt during a sorting task involving placing different coloured sugar pills into containers. Participants were college students, scoring moderate to high on a perfectionism questionnaire. The participants took part in 2 conditions. In the low responsibility condition, they were told to sort the pills in any way they wanted, because it was only for practice. In the high responsibility condition, participants were told that how they sorted the pills would influence the development of a colour system, making the distribution of medication safer to a poor country with low levels of education being severely affected by a virus. Results showed that both groups engaged in more checking behaviours in condition 2, including preoccupation with errors, doubt, need to check, anxiety, and desired additional checking time. Although participants were not diagnosed with OCD, the results are interesting, providing insight into how dysfunctional beliefs encourage behaviours to relieve anxiety. If this theory is correct, we can challenge the dysfunctional belief, and the sufferer may perform fewer compulsions. The most common and apparently most successful therapy for this is exposure and ritual prevention treatment, ERP. This has 2 components. The patient takes part in a graded exposure regime to the thoughts triggering their anxiety. For example, if the patient has intrusive thoughts of hurting their husband, they might watch a video on spousal abuse, then listen to a loop tape of their own distressing thoughts until gradually they can repeat this thought out loud in front of their husband until the distress levels significantly decrease. The second component focuses on strategies preventing the ritualistic behaviour, for example using refocusing techniques like singing or meditating to prevent mental rituals like counting. For patients performing repeated checking, this can be improved by restricting the number of checks performed or delaying their checking routine by whistling a happy tune. 75% of OCD sufferers who engage in ERP view it as effective for long-term treatment. Statistics for success in therapies like this show sufferers can gain relief. Even if the symptoms don't disappear completely, OCD doesn't have to be a lifetime sentence.
Created using Powtoon.